Beyond this, there are certain high output states which will also lead to heart failure. So you would have often seen one diagnosis called anemia and failure. So severe anemia leading to failure, heart failure. So that is a high output state which is resulting in heart failure. So what are the high output states which are going to result in heart failure like manifestations? Certain metabolic disorders can present as high output states. Excessive blood flow requirements, like there is an arteriovenous shunting that is going to lead to increased blood flow. So that is going to present as a high output state. Thyrotoxicosis is a high output state. Nutritional disorders like thiamine deficiency, beriberi is a high output state. And chronic anemia leading to heart failure, that is a high output state. Next we are going to see in detail about the heart failure with reduced ejection fraction. I told you initially there is an inciting event like a coronary artery disease, for example, and eventually the cardiac chambers are going to get dilated and hence there is going to be poor contractility. So what happens through these in this process is what we are going to see now. So there is an index event. Patient develops an acute ST elevation MI and the patient develops an inferior wall MI affecting the inferior wall of the heart. So the inferior wall of the heart is not going to contract properly. That is what is going to happen initially. So what the body does, it tries to, though one part of the heart is not contracting properly, the body wants to give sufficient blood supply to all parts of the body. So it activates certain compensatory mechanisms. The first one being the renin-angiotensin-aldosterone system. Then you have the adrenergic nervous system which gets activated. Then certain vasodilatory molecules are released which also cause vasodilatation and hence ensure that sufficient blood supply goes to the vital organs. So what happens and how this RAS system gets activated? When you have an acute ST elevation MI or an inferior wall MI as we discussed, and the cardiac output is going to decrease, this decreased cardiac output is going to stimulate the baroreceptors. You would have learnt about baroreceptors which sense the pressure changes. So because of reduced cardiac output, there is going to be reduced blood pressure that will be sensed by the baroreceptors. Normally the baroreceptors are going to have an inhibitory activity on the vasomotor center which is there in the brain. Normally, this is what happens normally. Okay. So normally they will have an inhibitory effect on the vasomotor center, which means there is going to be decreased sympathetic activity. This is what is happening normally to maintain homeostasis. But in case of heart failure, when the BP is going to drop, the baroreceptors are not going to give this inhibitory stimuli. So loss of inhibitory afferent stimulation from the baroreceptors to the vasomotor center, which means normally the sympathetic activity is under regulated, but in case of heart failure, the sympathetic activity is going to increase. So how is the sympathetic activity going to affect and cause compensation for the reduced cardiac output? Sympathetic activity will lead to increased sympathetic activity is going to lead to increased cardiac contractility. It is going to increase the heart rate. It is going to cause vasoconstriction of the peripheries. So when vasoconstriction occurs in the peripheries, the blood is going to get diverted to the vital organs of the body. These three mechanisms, by increasing the contractility of heart, increasing the heart rate, it tries to ensure that the reduced cardiac output becomes a normal or as much as possible a normal cardiac output. So it is ensuring homeostasis is again achieved. It is a compensatory mechanism. This is through the baroreceptors activation of the sympathetic or the adrenergic nervous system. On the other hand, this reduced BP leads to reduced renal blood flow. This reduced renal blood flow is going to cause release of renin in the kidney. So reduced BP on the other hand is going to cause decrease in the renal blood flow. This reduced renal blood flow will lead to production of renin from the kidney. What does renin do? It converts angiotensinogen into angiotensin. So on the other hand, the low blood pressure is going to result in low reduced renal blood flow. This reduced renal blood flow is going to cause release of renin. Renin converts angiotensinogen into angiotensin 1 and angiotensin 1 will further get converted into angiotensin 2 by the lung substance called angiotensin converting enzyme. Lung releases angiotensin converting enzyme which converts angiotensin 1 into angiotensin 2. If we take angiotensin 2, it has two actions. One is it is a potent vasoconstrictor. Same mechanism as in the sympathetic nervous system. Vasoconstriction causes reduced blood supply to the peripheries so that the central organs or the important organs receive sufficient blood volume. And angiotensin 2 also acts on the adrenal gland, causing release of aldosterone. So aldosterone, we know, is a substance which causes reabsorption of sodium and water, and aldosterone also has vasoconstriction activity. So reabsorption of sodium and water is going to increase the intracellular volume. So even though the cardiac output is low, we are increasing the intravascular volume. which means there is going to be an increase in the amount of circulating blood. So that thereby it tries to compensate that all organs receive sufficient amount of blood. And another one is again peripheral vasoconstriction, so that vital organs receive sufficient amount of blood. Vasodilatory peptides are getting released, like your atrial natriuretic peptide, brain type natriuretic peptide, bradykinin, prostaglandins and nitric oxide. All these vasodilatory peptides are going to cause dilatation of the blood vessels and ensure that sufficient blood reaches all the vital organs. So this is what happens in a brief period of time. So suppose patient, we take this in years, and this is the ejection fraction. Initially, if you have an inciting event at this point of time, patient develops a myocardial infarction this year. At that point of time, though there is damage to the myocardium, all these compensatory mechanisms ensure that the ejection fraction is still normal. So if this is the normal ejection fraction, say 56%, they maintain the ejection fraction in this range. It might drop a little, maybe 52%, and this is called as the compensated phase. So over a long period of time, this compensated phase is because of these compensatory mechanisms trying to maintain the. So to understand what happens during this compensatory mechanism, initially if patient develops an index event here, patient starts having a coronary artery disease or a myocardial infarction at this point of time, his ejection fraction was initially normal, and then though the heart's ejection fraction is going to drop because of poor contractility of the heart, though the ejection fraction has decreased, symptomatically if we see, the patient has minimal symptoms or no symptoms, because the compensatory mechanisms are ensuring that sufficient blood supply happens to all the organs. So these compensatory mechanisms keep the patient symptom free, there are no symptoms. But as the patient's disease process progresses, as the number of years increases, along the x-axis we have years and along the y-axis we have the ejection fraction. So as the number of years increases, the ejection fraction also drops, and this compensatory mechanism is not able to maintain the patient symptom free. In such a situation, then patient starts developing symptoms of heart failure. What are the harmful effects of these compensatory mechanisms? These are going to cause remodeling of the heart. That is, there is a particular structure for the heart, the particular way in which the myocytes are arranged inside the myocardium. All this gets changed because of the activation of this compensatory mechanism. Continuous sympathetic stimulation is going to cause this remodeling, and certain other inflammatory mediators, certain other cytokines are going to cause this remodeling. So finally, when this remodeling occurs, there is going to be damage and change in the shape of the heart. At that point of time, the patient is going to manifest with symptoms of heart failure. So in between, there is one period where the patient is symptom free and is happy, though there is an index event. Finally, only patient develops the symptoms of heart failure. So this is how the compensatory mechanism briefly tries to help, but on a longer run, the compensatory mechanism is responsible for remodeling, which damages the heart.